much, Chairperson. It's a great pleasure on behalf of Sky to partner with the BSCI for the CTO complication session. So without, as we are running out of time, I'll be very quick and try to get this program going. And we have a mission statement from Sky for mostly education, and I would encourage everyone to become a member. Complications of CTO also, as I think Dr. Nasrullah Khan very well mentioned, that sometimes it becomes a battle between the physician and the artery, and we might actually start causing more damage to the proximal coronary artery, vessel perforation, aortic root dissection, or damage to the collaterals. This is from Sudhir Rathore, and where from his experience at Toyahashi Center, he showed that the typical rate of death, bypass surgery or MI, is about 3 to 5%. Tamponade is the most common perforation, but I mean, it's the most drastic perforation. But the septal perforation appears to be the more common, about 3.8%, and side branch compromise can happen in about 5.1%. I think specific complications can happen either to retrograde approach and channel rupture, or potentially overwhelming ischemia from the donor artery, thrombosis of the donor artery, and prolonged ischemia that can cause a dominant collateral channel damage due to instrumentation. Somebody, I mean, Dr. Kamal Pansha asked a question about anticoagulation. Definitely keep it around 300. And obviously, all the CTO patients will have a prolonged DAPT if there is no high bleeding risk. So septal channel rupture, usually small and contained by myocardium, causing a small asymptomatic hematoma. Most of the times we can leave this alone. Otherwise, it keeps enlarging, then it actually needs the treatment. This is from Dr. Sabha, and you can look at some similar algorithms from Sanjog Kalra and Robert Riley and others as well. And even Sanjog has done from open CTO registry that the retrograde CTOs are associated with more complications than antegrade. And so whether you go for parallel wire technique as well as antegrade dissection reentry are more preferable, and you need to be really very careful whenever you go for retrograde. But if there is a good channel, you should attempt the retrograde. I'm not saying that you should not. So common complications, when you look at the bottom of this, is cardiac tamponade, thrombosis, side branch occlusions, dissection, embolization, including air, and because sometimes we deep seat the guides, and spasms also can occur in these people. So I think I mentioned about open CTO registry and progress CTO. The more higher JCTO score, the higher complication rates that can happen in these patients, because we are spending more time in opening up these arteries. So let's look at quickly some cases. A 75-year-old with a typical angina and anterior wall ischemia, and he was referred for a CTO. As you can see, the LADs are completely occluded. A wire is placed in the diagonal, and a retrograde attempt from RCA. And as we went through all these slides earlier, Dr. Nasrullah Khan as well as Dr. Arun and Omer have shown great cases. And I'll quickly only go and show. So this is a case that has been completed, stented the LAD. You should actually pay attention that there's something here outside the stent and near the carina of the LAD and diagonal. But we did not pay attention, so it was stented, and we're very happy that we got a beautiful result. And looking at later on, patient developed a cardiac tamponade and became hypotensive, and we recognized it. We tapped the pericardial effusion, and you can see that there is blood flowing out of the LAD now. What happened? So where is the perforation? So we put a covered stent in the LAD, but still patient is hypotensive and the blood is draining. So then put another covered stent in the diagonal, because sometimes at the carina, it is always difficult to know where that is coming from. You can see very clearly that it is probably from the junction of LAD and the diagonal. And so we took another covered stent for the diagonal, and after that, actually, patient did not have any further hypotension, and we did final kissing balloon inflations, and there is a flow through the diagonal and as well as into the LAD. So sometimes you might have to sacrifice the side branch with these type of perforations, and then open up the side branch with maybe 14-gram wire. So that's sometimes you have to do that. So that's the final picture on that. Here's a septal perforation. As I said, that the majority of them can be stopped. You can see that there is a septal perforation clinically inconsequential, no hypotension. There's probably no therapy is required. That to most of the times. Okay. And whether this patient has a retrograde approach to the right coronary artery injection with the corsair. And you can actually see that nice successful reverse cart, and but subsequent angiogram showed that there is a small perforation of the PLV. And so we kept waiting, maybe thinking that right now it's completed, whether we can, it'll heal on its own, and waited for 5 minutes and 10 minutes. It is still getting slightly bigger. And after 20 minutes, there is no point anymore, and it's getting much larger. So that's not going to close. We sacrificed that with the appropriate coils. And after 2 coils, there definitely there was no completely sealed off a perforation here. So 2 coils were given to that small branch in the PDA. So another septal perforation, you can, which we had to be treated compared to the first one. Here, this patient RCA CTO wire was not crossing, and multiple attempts were made, deep seating the guide, and ultimately, actually, there was aortic dissection, and with repeated puffs, the dissection kept increasing. And but immediately, the cure is trying to stent the proximal RCA to aortic junction. And so if you look at aortic dissections, you can classify them to 1, 2, 3. And 3 is the one that is we are always worried about. That is the cusp to aortic arch more than 4 centimeters. And most of the causes are guiding catheter trauma and repeated injections through that. And sometimes balloon rupture also can cause that antegrade dissection. In my last case, it was actually a NC balloon after doing a beautiful left main by DK crush stenting. My fellows went up to 18 atmospheres on the left main balloon inflation. Proximal optimization technique of, sorry, not 18, more than 22. And that resulted in aortic dissection, and I had to put a short stent again to cover that. Coronary artery dissections can happen. You consider minimize the contrast injection, consider mother-child catheters, and stent intracoronary entry point dissection with a conventional stent or a covered stent. The last one actually I did with a conventional stent, and that itself was luckily we were able to close it. So TEE, and somebody also asked the use of CT coronary angiogram prior to doing CTO is now recommended in complex CTO cases. I think in view of time, dissection is probably all of us are very good with it. And this is another case where there is a perforation and tamponade not immediately recognized. Use softer wires once you cross the main CTO. In this case, that was not done, and hence the Conquest Pro caused a dissection, perforation. And the people kept ballooning at the site of perforation, which actually really worsened it much worse. And the patient actually collapsed completely. So you need to balloon tamponade proximal to the perforation. And even if it is a little bit proximal, it is all right, So the treatment is obviously people who are older and female gender and having calcifications and high balloons to stent to artery ratio. These are the people who will have perforations. In addition to using any of these extra wires, hydrophilic coated wires, electroablative devices, etc. And so perforations for LS3, obviously you have to be worried about what needs to be done. Immediately covered stent, if you can get hold of it. Please make sure before you start doing CTOs, you need to have, or any complex PCI, you need to have covered stent in your cath lab. Brilakis has talked about nicely in this paper of his and in the textbook. Treat the main cause, covered stent, prolonged balloon inflations, while you're waiting for the covered stent to come from a different hospital that I had to do in China one time, and embolization with the fat coil or thrombin, and if it is a distal vessel perforation, and also maybe sometimes you might have to sacrifice that vessel by putting a covered stent across that artery. And so this is another mid-LAD CTO successfully performed. You can see there is a balloon in the RCA, and everything was done well. On the LAD was being concentrated. As you can see, people are concentrating on the LAD. And at the final injection of the right, here there is a thrombus in the distal right. And so obviously you need to not only pay attention to the main vessel that you treated, but also the donor vessel that you went through. And so many devices go through this donor vessel, it can cause a thrombus. So just a gentle thrombectomy is enough for most of these patients, and making sure the ACT is around 250 to 300 towards the end, and if need be, you can give a little bit more heparin. So I think in view of time, I'll go to most important points. You need to worry about the radiation, antegrade versus retrograde. As I mentioned, more complications can happen with retrograde. Prepare detailed PCI strategies based on the high quality angiogram without panning, as mentioned by Dr. Khan. Measure ACT and keep it within your target range. For us, it is about 300. And everything should be seen on the same screen at all times, and use guiding catheters more than 7 French without a stiff and tapered tip. Do your best to identify the entry point into CTO, and IVUS or any OCT should be done when an antegrade wire passes through an occlusion into the distal side branch, and use spring coil wires as your first choice of collateral channel tracking when vessel course is not clear at all. And the knuckle wiring is the safest when vessel course is not clear at all. And Omer prefers parallel wire, that also could be done. Osteal LAD CTO has the highest risk of serious complications. And so this, I would not say that the beginners should start with an osteal LAD CTO. And a stent delivery into the left circumflex should be guaranteed, just in case if you are going with the LAD CTOs. So take home message, detect perforation early. Don't ignore subtle findings, as I showed you in a couple of cases. Inflate a balloon to stop bleeding, and perform pericardiocentesis if unstable. Treat the cause, large vessel perforations, covered stent. Distal vessel perforation, fat or coil embolization. Number 4 is most important, remain calm. Communicate with the team. Everyone in your team should know what is happening. So in the take-home message, people who are at a higher risk of complications, also low ejection fraction, less than 35, active heart failure, elevated EDP or wedge pressures more than 35 millimeters of mercury, large area of severe ischemia, jeopardy score being high. Even in the best of best hands, complications can happen. In these type of patients, have a balloon pump or an impel or ECMO also available, because we sometimes think we ignore that ejection fraction or hemodynamic collapse can happen, and people might need these support devices. With that, I'll stop here. Thank you very much.
Thank you, Dr. Ramesh. That is very brilliant lecture, because we used to learn from the complications mainly. So this is a very good lecture indeed. So I want to take some comments from our chairperson, Dr. Sanjay Karla there. Dr.
Yes,
Sanjay Karla,
yeah, I'm here.
please give some comments.
No, I really enjoyed all of those lectures, especially the case-based examples that we have used throughout. I think the goal with good CTO PCI programs is start slow, be careful, and start programmatically. So if you're going to bring CTOs forward, make sure that the communication with the team is particularly strong so that they understand why you're doing the procedure and the planned procedure that you're going to perform, so that everybody understands not only what you're trying to achieve, but what can potentially go wrong. And so that you're prepared for it. One of the things that Dr. Daggubati just brought up was how important it was to communicate with the team. And having done a 6-hour case today that I knew was going to be a 6-hour case, it was critical that the team knew exactly what we were doing, why we were putting the patient on a tandem heart support pump, and why we were going to have to use a bifurcation technique in the midst of an epicardial retrograde to be able to recanalize this. Otherwise, the room would have ran away and said, this is nuts. There's been a lot of questions about whether or not we should do CTOs in asymptomatic patients, and I think there's been some really nice discussion on the chat. As Dr. Kalyana Sundaram has pointed out, and as Dr. Daggubati and others have pointed out, the importance is doing what's right by your patient, right? So if you've got an asymptomatic patient, it's hard to sell doing anything to them unless you can actually put them on the treadmill and prove that they are symptomatic, prove that there's clear ischemia. The one thing that I will mention, this is my personal opinion, the data bear this out to a degree, but not in a randomized trial format, is that in individuals who have LV dysfunction with retained viability, attributable to a CTO territory, you have an independent indication to revascularize, right? But once again, that discussion has to come with an important informed consent around why you're doing what you're doing, and the honest sort of risks and benefits and complications, potential complications associated thereof with your patient. But really well done. That was a great session.
So, Dr. Ashok sir, are you here, sir? Ashok sir here?
Is not with us.
No, he's not here. Yeah,
No,
he's
he's even messages right now. So I knocked him. That would be great if Ashok sir is here. But now, Jamal sir.
Yes, thank you. It's a very interesting and learning session. We are grateful to the Sky Authority as because they have made this program in collaboration with Bangladesh Society of Cardiovascular Intervention. As the secretary of Bangladesh Society of Cardiovascular Intervention, I have the gratitude to you, and I am congratulating you to arrange this program. And regarding this program, we have learned much more regarding the CTO management, both integrate as well as retrograde. For the younger colleague, I have to say, whenever you want to do a CTO, your team must be prepared before your team. Your cath lab setup should be prepared, as because you will have to have all the materials what is essential regarding the different types of wires, balloons, and last not the least, a covered stent. With this backup support in your cath lab, then your team, then enthusiastic team should be there, and then expertise is also important, and all together will have the goal to success in this CTO. So CTO program is a different program, and this program needs specific expertise as well as all these materials, which is essential. Thank you all the foreign speakers as well as my country man speaker, Dr. Kaisan Nasrullah Khan. And thank you, Sky Authority, for collaborating with us. Hope that you will remain with us in our heart, in the heart of Bangladesh Society of Cardiovascular Intervention, as well as with Bangladesh. Thank you once again.